Hello, my name is Abigail Vélez. Today I'm going to talk about the effect of estrogen receptor-beta on mandibular condylar growth. First, definition. Estrogen is an important modulator in the metabolism of bone tissue. It has an effect on osteoblastic differentiation, decreasing cell proliferation, regulating differentially the expression of the extracellular matrix, which also explains the molecular mechanisms of growth and remodeling of bone by estrogens. The estrogen increases inflammation and decreases bone resorption. Next, a video.
The estrogen receptor, molecular and cellular mechanisms. Like all steroid hormones, estradiol circulates throughout the body via the vascular system and freely diffuses through membranes of cells in the body. In most cases, estradiol molecules travel through the cellular cytoplasm and then migrate into the nucleus, where the steroid exerts its major effects on cellular functioning. Steroid hormones, including estradiol, exert their effects by interacting with a special class of proteins called steroid receptors, found in the cells of target tissues. These receptor proteins have very specific binding properties and therefore associate with steroids and other chemicals in very particular ways. Estradiol and other estrogenic substances bind to the protein called the estrogen receptor. Although estradiol binds and activates estrogen receptors in both the cellular membrane and the cytoplasm, most of its sustained effects on cellular functioning are the result of its interactions with estrogen receptors in the cell's nucleus. In the absence of estradiol, estrogen receptors are distributed throughout the cell nucleus. These receptor proteins are large, complex structures that include a pocket called the ligand binding domain, into which estradiol will eventually bind. In the absence of estradiol, receptors are associated with a large cluster of proteins called chaperones that serve to keep the receptor in the correct conformation to allow estradiol to approach and bind to the ligand binding domain. When estradiol enters the nucleus and begins to interact with the receptor, the chaperone complex dissociates from the receptor and estradiol binds to the exposed ligand binding domain. As a result of this interaction, receptor complexes form clusters within the nucleus in the region of the chromatin.
Second, applications in dentistry. Estrogen receptor-beta has a liberating effect on the osteoprogesterone, OPG, being this protective of inflammatory mechanisms. So the woman with a lack of this circulating hormone has an increase in inflammatory cytokines, inhibiting the formation of new bone, consequently promoting reabsorption, condylar, and decreased bone dentistry. Next, a video.
In our office, we do zero surgery to treat TMJ. In our office, we know that 90% of headaches come from muscle fatigue. So a lot of the symptoms that people seek out treatment for their TMJ are related to pain. So what we know about the muscles is that if we can get them calm, then that means they're in a good balance. And if we can get a good balance with the teeth, how the teeth meet together, how the muscles meet together, then we can get you in a better position to where the TMJ is not painful or anything like that. That being said, there may be indications where other doctors may need to be involved. If you were in a car accident, or you had some kind of accident where your bone to bone, how they meet are causing issues, or physical therapy. So there are indications for other modalities in the treatment of this, but what we found is that 90% of the time, headaches are caused just simply by muscle fatigue without any accidents causing any TMJ problems. In our office, if you were to come in, this is how we would treat you. We would take photos. We're going to take a look how the teeth come together. If the teeth aren't coming together properly, we know that there's also going to be a muscle imbalance there. If there's a muscle imbalance, there's going to be fatigue, and that can also relate to headaches. So what we'll do as our first course of treatment is to test to see if we can get your bite in a comfortable position and get the muscles relaxed. We'll make what's called an orthotic that goes on your lower teeth without doing anything permanently to your teeth. We're going to be adjusting the bite. We're going to be running computerized scans to see how your bite is tracking and how the muscles are being relieved. And there's all these facets that we're going to be doing over a 6-week period of time to see if we can get you comfortable. If we can get you comfortable and you start feeling more comfortable, then we can find out permanent options for you. Permanent options may be moving your teeth with orthodontics into that position of your comfort, and other options may be doing porcelain crowns and veneers to get your teeth into that position where they have a home. And sometimes it's a combination of both of those, moving your teeth and rebuilding some of the teeth. A lot of times when we rebuild some of the teeth, a lot of the teeth are already worn so much that we don't have to do a lot of work to the teeth because we're adding and building up to the teeth. So in our office, that's kind of how we treat our TMJ patients, and surgery is not done in our office.
Third, pros and cons. Pros. First, the probability that it affects men is low. Second, the severity of symptoms is related to the age of the patients. Third, the prevalence is lower for postmenopausal women. Cons. The first, they usually occur after puberty, with a peak in women between the ages of 20 and 40. Second, the prevalence is higher for women or reproductive age. Third, as there is a low concentration of estrogens, its protective role in bone metabolism would be enhanced, increasing inflammation and reabsorption. Next, a video about a testimony of a patient who suffered from temporomandibular disorder.
The sad part is all the professionals that you saw, no one had a clue.
No.
No one had any idea that this
I had
would be
never
something.
had an MRI
Yeah.
before. Before
Right.
you, I mean.
Well, we did the
here-
first one.
Mhm,
We
yes.
started the process.
And I'd never had an MRI.
Where are you from?
I'm from Rock Island, Tennessee.
And can you tell us how we met?
I actually was on the internet looking for anyone who had TMJ problems,
Right.
and I came across YouTube videos of it was you.
Yeah.
And people who were visiting you and talking
Sure.
about how you help them.
And what was your
And-
problem? Why were you looking?
I just had severe pain in my jaws.
Can you point to where?
Oh yeah, it was mostly on the left side, but the right side hurt too. It
Uh-huh.
was very painful to eat.
Had you been to other doctors? Did anyone else?
Yes, I had been to several dentists, oral surgeon, and everyone just always wanted me to wear a splint.
A night guard.
A night guard.
Like it's going to fix it. Right. Didn't fix it, did it?
No.
We screened you. We actually looked with an MRI and a CT. And we looked at things. No one had ever done that for you before, had they?
No. Mm-mm.
And as I recall, we wound up seeing things that we knew were beyond our scope. In other words, we couldn't address this with simpler things in general dental world. So I referred you on to a TMJ surgeon,
Yes.
Dr. Piper. Can you
Yes.
tell us what happened there?
We, after my visit with you, right after we got home, like the next week, I called and, talked to him about it and said that I had been to see you like the previous week, and they went ahead and scheduled me an appointment. So I went to see him in April of this year.
Yeah.
And he had an MRI done.
Another one.
Another MRI.
Mhm.
They had done pictures and then also a CT scan. And evidently my problem was more severe than what I thought. And I knew that it was going to be bad from what you had told me.
Yeah.
But it was pretty bad.
The jawbone, the AVN, avascular necrosis, right?
Mm-hmm.
Basically, the bone was dying.
And my
Yeah.
discs were displaced.
Like way out. And inwards, too, if I remember right.
Inward.
And that's what kinked the blood supply,
Yes.
killing the bone.
Yes.
Yeah. Yep. So everyone else was putting you in splints, like that was going to fix
Yes.
a piece of dying.
Fourth, issue applied in Ecuador. In Ecuador, this issue is little known. However, there is some information about women with TMD who have a regular menstrual cycle. Facial pain increases in relation to the drop of estrogen produced in the late luteal phase and reaches its peak during menstruation, when estrogen reaches its lowest level. And finally, the number 5. Conclusion. The TMJ degenerates with age, between ages 73 to 75. Some authors claim that women of childbearing age are less likely to suffer from TMJ diseases. On the other hand, it is more likely to occur in women between 35 and 54 years of age because in the article hyaline cartilages, estrogen ceases producing an alteration in the growth of the cartilage, predisposing women to a greater probability of develop age-related accelerated degeneration of the TMJ. Thanks.